Okay, cool. So thanks for coming today. So today we've got a guest speaker we did last week as well, or last Tuesday as well. So this is Dr. Kyung. He's one of my collaborators in radiology and bioengineering as well. He's going to talk to you about perfusion imaging, which is one of his research specialties. And some of this material can make it onto the file, so please pay attention. And I'll let him sort of take it from there. He also offers next quarter a really great class together with Holden Wu. Holden will speak, I forget, Tuesday or Thursday next week on, I think, fat water separated images. But anyway, together they teach a really nice MR course that follows kind of directly on the material that you get in this class. So if this class has been the most amazing experience ever and you want to continue, then you should look up this class as well. Cool?
All right.
All right, have at it.
Thank you. Yeah, so as Dan said, we have the PBM 229 will be offered next quarter. So if you're interested in, let me know. If for bioengineering students or other students, you need to have the PTE number. So let us know, and then we can provide the number. All right. So today I'll be talking about perfusion imaging, particularly using so-called a technique called dynamic contrast enhanced MRI. This is basically when you have a contrast agent injection and then try to look at how the tissue behaves. And then the technique is actually really popular for cancer imaging. So whenever you have cancer imaging, perfusion or DCE-MRI is actually one of the major components. So it actually starts with the tumor angiogenesis. Typically when cancer grows certain size, it has to have a vascular structure to support the growth of that tumor. And so because of that, the recruited tumor vasculature is different from the normal vasculature. And then we're using a contrast enhanced MRI or the extra injection of the contrast agent, try to differentiate the normal vascular structure versus abnormal structure. Again, feel free to let me know if you have any questions. So again, this is the main kind of core difference between the normal versus abnormal. Typically, the tumor has very unstructured kind of vascular structure, and then because of that, when you inject the contrast agent, the responses are different, and then that way you can actually create a different contrast. So this is an example of MR with the contrast injection. So this one is called T1 pre-contrast. So without having the contrast agent injection, if you just have a T1 weighted imaging, you don't see any differences. Whereas if you have a T1 post-contrast, meaning you inject the contrast agent, wait a certain amount of time, and then you acquire a T1 weighted imaging, then because of the difference in a T1 relaxation, you're going to have a brighter signal in the tumor area, and then a little bit darker signal in the normal area.
Okay. So this the question for the students is the contrast agent, does it shorten the T1 or lengthen the T1?
Okay, why? Can you tell me the reasoning behind why it's a shorter T1?
Why contrast agents?
Yeah, so yeah.
I mean, I'm probably wrong. But I'm just
That's okay.
Probably because they may lower the local magnetic field, like the spins are exposed to.
Okay. I mean, so I'm not asking why contrast agents shorten the T1. It's more kind of like when you see this hyper intensity, brighter signal, and we're using a T1 weighted imaging, does it mean always a shorter T1 or longer T1, or can you tell me, anyone? Why?
I remember that signal that well, first of all, what method of
It's an RF full gradient anchor sequence, right?
Okay. I'm not sure if I remember the signal, but if you like shorten, where is this picture? Shortening the T1 increases the. I mean, tissue is like shorter, like the short T1 higher.
Right. I mean, that's roughly right. I mean, the main idea is actually so whenever you have a shorter T1, that means it recovers faster in a longitudinal magnetic, and then using a T1 rated imaging, having a higher signal means it has a much more recovery for the longer magnetization. So that means it has a shorter T1. So again, I'll be talking about why this area has a shorter T1, but at least when you see it before and after injecting a contrast agent, you will be able to see that the certain other tissues are behaving a little bit lower signal, and then a tumor area having the high bright signal, and then that way you can actually differentiate these two tissues. Okay?
I really like the question because I think you said why is it brighter? There's probably 11 reasons it's brighter. Yeah. Right? So we only touched on a couple, right?
Yeah.
The other one I would add is that it has to do with where is the contrast agent present? Right? So you administer the contrast agent to a patient in a vein, right? And you're going to probably get into this, but if it shows up brighter, it means there's more contrast agent in that specific location.
I mean, we'll get to the details. All right. Okay. So I'll be talking about the contrast-enhanced MRI. So the first way that you acquire the contrast-enhanced MRI is actually just getting one post-contrast images, so that you can actually see the bright signal, or you can actually get a pre and post, and then you can see the difference between these two to create a better contrast between before and after injecting contrast agent. Or you can have more kind of intermediate fashion so that you can see how the signal changes over time. Or in a better way, actually you can get a much higher frame rate so that you can actually see the signal evolution over time. Okay? So these two techniques is so-called contrast-enhanced MRI, but then having a fast dynamic acquisition, so-called it's a dynamic contrast-enhanced MRI, or DCE-MRI. So the DCE-MRI, particularly, the frame rate is important. So, you may have like 4 different frames over certain time. In this case, maybe like 4 to 5 minutes. And then you only get 4 points. And then when you look at this only a voxel location, then you will have some changes over time. Or you can actually develop much faster technique so that you can have multiple rates, and then you can see a complete signal behavior over time within the same time duration. Okay? So in this case, this one is so-called high frame rate DCE-MRI. This is called a conventional DCE-MRI. A lot of research is going on how to improve the temporal resolution, spatial resolution issues. Again, this is the case with the high temporal resolution DCE-MRI. And when you look at certain location, you can see the behavior or the temporal behavior or signal uptake is very different compared to other locations. So again, as I said, the high spatial, high temporal resolution is important because temporal resolution will give you a better depiction on your dynamic behavior. Spatial resolution is important to depict the normal versus abnormal tissues. Okay? So in terms of like detection of the tumor, the spatial resolution is important. And the characterization of the tumor, it's actually very important to have a very high temporal resolution. So to balance those out, a lot of techniques were actually developed using a compressed sensing, iterative reconstruction. But in practice, a lot of cases are based on the case-based data sharing scheme, so-called twist or disco. So this is an example. When you have a DCE-MRI, when you just have a pre and the post-contrast, and when you look at the subtraction, you may actually see like, okay, there's a bright signal here and here, but you don't know what is what. And it's really, really hard to differentiate what is more aggressive tumors or less aggressive tumors. But when you have a high temporal resolution imaging, you can see the red curve has very high and going down fast, whereas the green has actually very slow uptake, right? So even though when you look at the subtraction, it's hard to tell the difference, but when you have a high temporal resolution imaging, you will be able to differentiate these two. But then the question is how? It's a next question. It's based on a pharmacokinetic modeling, and then you can quantify something so that this one has some number, this one has some number, so that you can differentiate the blue versus green tissue. Okay, so as I said, the DCE-MRI is basically having a multiple measurements, very much 3D acquisition, go on so that it has a temporal resolution. And then you inject the contrast agent during that acquisition so that you can kind of capture that initial uptake of the contrast agent like behavior. So the outcome will be you're going to have a 3D imaging with different time frame, like a movie, like a 3D movie type thing. And then when the total acquisition time is around like 5 to 6 minutes. And after that, if you look at a certain location, you will be having this temporal behavior. And then the idea is actually based on this temporal behavior, you try to understand the physiological meaning of it. Okay? Any questions so far?
During this time period, you keep injecting the contrast.
No, you're injecting just once. And then again, you're injecting a contrast agent into the vein, and then it goes to the heart, and then it circulates over the body, right? So there's a first pass and the second pass going and so on and so on. And then every time you go, you have a different kind of responses.
So as you watch the video, you see that as you watch the result and MRI output, you see the different image with tissue changes.
Yes. Yeah. So again, this is what a signal intensity over time at this location, correct? Right. What that means is actually this one has a little bit darker, but by the time when you inject the contrast agent, it goes up. The signal intensity goes up, right? At different locations, it may be like going really high and going down, or some different location may have like a very slow up slope curve. Okay. So again, depending on a different location, you will have a very different responses. And then the question is actually, can you quantify that kind of signal behavior and then use it for tensor characterization and detection?
For different sites, will they have different delay, time delay?
Why do you think so?
I just think the perfusion rate is different in different tissue.
Okay.
So maybe, yeah.
I mean, there is some differences, but normally the differences are subtle compared to a temporal resolution, but there is definitely a little bit local differences.
Okay, and the contrast will stays in that tumor site, or it will just go like it stays in.
We're gonna talk about it later. Yeah. I mean, again, that's a great question, right? And that way you can actually somewhat understand the tumor characteristics. Some tumors maybe like you contain the contrast agent longer, or some tumors maybe actually take the contrast agent very rapidly, but then spits out very rapidly, right? It depends on the kind of biological status. Okay, so the way that you understand the quantitative DCE-MRI is basically when you have an acquisition scheme, you're going to have a 3D with different time points and signal intensity. Okay, so you're going to have each one to be 3D imaging, and then each one has a temporal resolution, and then you will see that each tissue has different kind of signal uptake, right? That can be formulated as signal intensity over time. And then using a so-called MRI modeling, and based on an assumption of relaxivity of the contrast agent, your repetition time that you're assuming, and T10, which is pre-contrast T1 value, and your E1 variation, and then you can convert it to contrast agent over time, contrast agent concentration over time. Okay, so using an MRI modeling, you know what pulse sequence you're using, you know what sequence parameters you're using, and based on that, you can convert from signal intensity to contrast agent concentration, which is CT over T, and then based on that, using a pharmacokinetic modeling, you can quantify something, so-called a quantitative imaging biomarker, such as K-trans and or VE. Okay, and the K-trans and VE will say like, okay, high K-trans means high uptake, high VE means faster kind of wash out, so on and so on. So having a different value will give you some sort of characteristics of temporal behavior. Okay, so I'll be talking first about MRI modeling, and then second I'll be talking about the pharmacokinetic modeling. Okay, so again, each one has very different kind of aspect. Again, you're assuming SI is given with high spatial, high temporal resolution imaging, and then based on that, we're going to convert it from SI over T to CT over T. Okay. Alright, so the topic today will be, I'll be talking about conversion from signal, MR signal, to contrast agent concentration. And then that requires T1 measurements and a B1 inhomogeneity consideration. And also the conversion from contrast agent concentration to quantitative biomarker. And also some of the aspects related to post-processing. Okay? So the first one, again, you have SI of T, and you need to convert it to CT of T, okay? So assuming you're kind of like in the body and then you're injecting contrast agent, as I said, into the vein, it goes to the heart, and then it spreads out to the body, right? That means you have a specific contrast agent concentration. It goes into the body, and then it changes the relaxation rate. So depending on the location, depending on how it takes that contrast agent, the contrast agent will change eventually relaxation or tissue relaxation rate, like T1 and T2. And then, because of that, it will change your signal intensity, right? This is kind of the chain reaction. You inject the contrast agent changes the relaxation, and then when you have a different relaxation, using either T1 weighted imaging, T2 weighted imaging, your signal will be different. And in this context, we're using a T1 weighted DCE-MRI. So we are acquiring MR using T1 weighted imaging, and then you're looking at the changes in the T1 relaxation, okay? And this is kind of the movie, like during this time, you're injecting contrast agent, and you can see the signal intensity changes over time, okay? And this is a breast tumor. Okay, any questions? All right. So the first one is actually how do we kind of make the signal intensity to like relaxation changes, right? Or how do we connect the relaxation changes and signal intensity? And back to the question related to why the signal is higher when the T1 is short, is because of this. So this is so-called signal equation when you use a so-called RF spool gradient echo sequence. So when you use RF spool gradient echo sequence, the signal will be proportional to this context. Okay? And then you can see the TR is something that you choose, right? Whenever you run the RF spool gradient echo sequence, you choose what is the repetition time, and you know what is the flip angle, right? You choose your flip angle. So when you know flip angle and TR, the only unknown is what? T1, right? And you measure the signal intensity. So you measure signal intensity, you know TR, you know flip angle. The only thing is actually T1. So you can calculate what is the T1 changes over time. Okay? So this is kind of the relationship between signal intensity and T1 relaxation time. Again, this is not a linear relationship. It's very different relationship because of the exponential term. But anyway, it's possible to kind of map it. So whenever you have a signal intensity changes, you can actually calculate what is the T1 relaxation changes. Okay? In that case, you have SI of T to T1 of T. All right? The next, yeah.
How do you know the flip angle when we use the contrast agent? Use some magnetic.
So you guys have the scanner lab, right? The MR lab, right? So in the scanner console, you just choose what flip angle you want to use.
Yes, but for example, you choose because we use the contrast agent, alright? And it means we use some paramagnetic molecules. It means we have B1 inhomogeneity. It means our flip angle is changed.
Okay, so
you are right. We apply 50 degrees, but how about the tissue? Tissue sees 50 degrees.
so it's a two separate question. I think so. If you choose 50 degree, your sequence will run 50 degree. But whether the tissue will be behaving as a 50 degree is a separate question. Sure, there is a B1 variation. I don't think the contrast agent will like increase the B1 variation. It was more tissue conductivity issues. I'll be actually talking about the B1 issues later, but the B1 issues is more kind of the shape and a tissue. not the contrast agent. The contrast agent typically just perturbs the relaxation rate only, so the T1 and T2. So if you have a tissue, it will change your T1 and T2, meaning when you inject the contrast agent, considering there is no B1 variation, this will be constant, but this will change. So only the contrast agent will change T1 and T2 component, but this one is purely T1 rated, so there's no T2 components. That way, it only changes the T1. But in practice, whenever you have high field imaging, like 3T or 7T imaging, there's a B1 variation, meaning there's ambiguity on flip angle side. But considering there's no B1 variation, that means the flip angle that you're assuming will be implemented as exactly as it is. Okay? Does it make sense? Okay, so the next one is actually, so you know what is the T1 changes, right? Then how do we know the contrast agent concentration changes? This is so-called relaxivity. And a relaxivity is basically whenever you use different contrast agent has a different relaxivity. So, some of the labs, they're actually developing a contrast agent has very high relaxivity, meaning, it actually changes a small concentration within a very small concentration changes, you can actually have a much higher relaxation changes, right? The slope is basically the relaxivity, and as you can see, this one is actually 3 different contrast agents, and each contrast agent has a different slope. And then, if you know the slope, right, then you know changes of the T1 or the R1, which is 1 over T1, and you can actually calculate the concentration changes. Okay? So the logic is actually you measure the signal intensity over time, and you convert it to T1 over time, and then it will be converted to CT or concentration over time. Okay? And each step, it requires the equations. Again, the first one from signal intensity to T1, you need to know exact signal equation, and you need to assume what is TR you're using and the flip angle you're using. And here, from T1 to contrast agent concentration, you need to know what is relaxivity you're using. And typically, whenever you know what contrast agent you're injecting, they always provide the relaxivity at a certain field strength. So, for example, here there's a publication of Magnavis, Gadavis, and a multi-hands. Each one has very different relaxivity. Okay?
We haven't talked about relaxivity specifically, so could you say a little bit more about that?
Yeah, so relaxivity is basically, again, this is a slope, right? High relaxivity means if you change like 10% of the concentration, that means your relaxation changes is higher. Okay? That means you use a little bit of a fraction of the contrast agent, and then it changes, shorten the T1 much higher. Again, shorten T1 means higher signal, right? So in general, whenever you have high relaxivity, that means your SNR will be better because T1 gets much shorter. Okay? In this context, we're not really looking into the SNR perspective. We're more looking into how do we convert from signal intensity to concentration perspective. Then we're just using a lookup table type thing. But in practice, having a high relaxivity means it's going to give you a better SNR performance. So, each one has a different relaxivity, and at different field strength, your relaxivity will also change. Typically, when it goes to the lower field strength, relaxivity goes higher. So the lower field having a higher slope, a higher field having a lower slope, but still, it's actually more than one. So whenever you have 10% changes in the concentration, you're going to expect much higher changes in the relaxation. Okay? Any questions? Yes, yes, yes. Yeah, so that's a great question. The main changes will be whether the contrast agent goes into the intracellular space or not. In most cases, it's not. It doesn't really go into the intracellular space. Then it's actually pretty much the same, like a free solution situation. But if the contrast agent goes into the intracellular space, then things are quite tricky. So for example, some of the iron oxide-based nanoparticles, they goes into the intracellular space later, like 48 hours or later. then relaxivity changes are different. So you have to have two different relaxivities. One is the free space versus intracellular space. I mean, some people do that, like just doing I think in vitro studies or something. But I don't think it's well studied because those contrast agents are not practically really used or clinically used. So it is still in research. Yeah, but I think that's a great question. So anyway, so this relaxivity will be given from each contrast agent, and then when you know this, you can actually map it from T1 or R1 to concentration. Okay, so you have a mapping. So one from signal intensity to T1 and T1 to contrast agent concentration. Okay. All right. How do we map it? Again, it's not simple linear equation. There's another component here. It's called T10. So again, this T1 over T is coming from signal intensity, right? And then you convert it based on TR values and flip angle. And then this gamma is relaxivity. This is given from each contrast agent. And CT of T is something that you want to calculate. Okay? So this is given. This is somewhat, again, I haven't really talked about it. This is given. This is something that you want to know. All right? So T10 is also very important to convert it from T1 over T to CT of T. And this is so-called pre-contrast T1 value. And either you can assume or measure. There are two different ways. Assuming T10 is actually kind of risky, but it's easier because you don't have to worry about it. Measuring is better, but also it has another kind of consideration or practical consideration that you need to include. VFA, or variable flip angle imaging, is the most popular approach to measure this T10 value. And one of the main kind of issue for the VFA imaging is maybe I will talk later. So this is a typical the DCE-MRI acquisition. If you want to have additional pre-contrast T1 measurements, you need to actually add an extra time, so-called VFA imaging time, and then each one has a different flip angle. So for example, in this case, for the breast DCE, you're using 5 different flip angles, 2, 5, 9, 13, 15, and then again, each flip angle has a different contrast, and then based on that, you can measure a T1 value. And again, the VFA T1 mapping is very sensitive to the B1 variation. This is one of the major kind of issues that you need to address. The B1 variation at 3T is around like 30 to 50%. And you can see in the brain, there's always hot spot in the middle. Higher, like a reddish color means a higher B1 variation. And then the greenish color means lower B1 variation. What that means is actually you want to achieve maybe 90-degree flip angle, but then red area means more than 90 degree, and then the greenish or the bluish area means less than 90 degree. Okay, so it is an important factor because whenever you calculate the T1 based on VFA, it exactly assumes you're achieving a right flip angle. If there's any perturbation in a flip angle, your calculation is wrong. And this is the breast example. There is a huge difference between left and right breast. So, whenever you try to measure a quantitative value from left and right side, there is a discrepancy. This is abdomen. Abdomen has a kind of a weird shape. One spot is hot, and then a couple of very low spots, and then it creates an issue. The leg has also kind of different patterns too. Okay, so it is possible to measure it, but again, this is one of the things that you need to really consider when you try to measure a T1 at high field, particularly 3T or higher. Okay? Again, this is an example that you can compensate the B1 inhomogeneity at 3T. This is the T1 map without B1 compensation using VFA. And then whenever you measure a B1 and try to compensate it, you can see the difference is actually much more reduced. The difference between left and right is reduced by having a B1 compensation. So it is an ongoing kind of research project. A lot of people try to find a better way to measure it, better way to compensate it, and then try to improve the quantification side. And this is one of the project that we're also still ongoing. Another thing is actually, so because of the B1 variation, there is an inter-scanner and intra-scanner variability. This is an example that we scan a same volunteer for 3 different scanners, and then we try to measure a the T1. Again, it's the same volunteer. We scan on 3 different scanners, right? The T1 has to be consistent. That's the kind of the bottom line. But if you look at the results, they're not the same. The main confounding factor was the B1 variation. And then whenever you compensate the B1, you can see across 3 different scanners, it actually becomes very consistent. Okay? Any questions?
The B1 changes over different scans.
B1 doesn't change over time, but B1 is basically related to where you position and how you position. So if it's a feet first, head first, it's going to be different. If the patient is kind of like, how do you laying down on a table, it's going to be different. So it has to be measured subject by subject at each scanning.
So B1 plus need to be measured.
Yeah, it has to be measured. It cannot be assumed before you scan something.
Is it different from the B1 sensitivity map that are usually provide?
Right, that's called B1 minus field,
Okay.
and that's different. Yeah. This is B1 minus is more so-called intensity variation. B1 plus is actually more intensity / contrast variation because it actually changes the flip angle, whereas the B1 minus is just changing the overall signal intensity. So B1 minus sometimes you can say it's easier to compensate it if you know the pattern. But here, B1 plus is not easy to compensate it, even though you know the pattern.
So for every scan, you have to get B1.
Yeah, that's the bottom line. Yeah, there are 2 different ways to overcome it. One is actually measure and compensate. Another is actually to develop a technique that's insensitive to the B1 variation. So I think we're going to cover advanced topics in 229 about an adiabatic RF pulse design. That's the RF pulses that's immune to B1 variation. So there's a technique that immune to do that, but it has a limited application. You cannot use it for all different sequences. So in a regular cases, I think this is the best way. You measure it and then compensate it later. Okay. Any questions? All right. So in summary, there is a pre-contrast information that you need to acquire. And again, there are 2 different ways. Either you're assuming something or measuring something. The issue is actually typically whenever there is a tumor or hemorrhage, T1 values are different, and each subject are having a little bit different T1 values. So assuming T1 is a little bit risky whenever you really want to have an accurate calculation. Measuring T1 is better, but then again, it has a B1 variation issue, so you need to measure and then compensate it, try to be creating a more consistent T1 values. Okay? All right, any questions? Okay, so that's from SI to CT of T, okay? And the next question is actually, how do we calculate the K trans KP? Those are more quantitative imaging marker, like showing a differences in a tissue status, okay? So this is basically you're assuming you know the CT of T, assuming everything is perfect, and you know what is CT of T, and then can you calculate those quantitative biomarkers, okay? So how do you do it? Again, what is pharmacokinetics? Pharmacokinetics is basically how the drug or contrast agent kind of reacts in the body, right? It's related to the doses of drug or concentrations of drug at various locations in the body. In our context, we're not thinking about drug, we're thinking about contrast agent, okay? But same thing, it's whether the drug concentration versus contrast agent concentration, they are the same thing. There is an input and the clearance. It's the same thing, okay? Yeah, so again, to apply for the pharmacokinetic modeling, I think you need to understand the compartment models. And we're going to actually use very simple compartmental kind of division. One is what? Vascular space, meaning you have the vessels, and then extracellular, extravascular space, which is not the vessel, not the cellular space. There is an intermediate space or interstitial space. So that's so-called EES. And then next one is actually intercellular space, right? Cell and inside cell, okay? So we're going to actually divide it into 3 compartments. And particularly for the contrastation, MR contrastation, it doesn't, as I said, it doesn't really go into the intracellular space. So mostly we're actually looking at interaction between these two. Okay? Contrastation goes into the vascular space, and then it leaks out to the EES, and then going back, and we're actually looking at a transfer constant, how fast it goes from the vascular space to the EES, and how fast it goes back to EES to the vascular space. Okay? And we have some sort of assumption. It has to be well mixed, and each compartment has to have a uniform concentration. And we want to know how the average concentration of the drug varies with the time in the compartment. And mass can be transferred between different compartments. And inputs of the drug or contrast agent entering the body, and then output will be the clearance. Okay, so input is the extra injection, and then the clearance will be, depending on the contrast agent, will be either kidney or liver. Okay. And again, each compartment should have volume and average concentration of contrast agent in this context. And the main principle is actually we're assuming mass is conserved. And we're actually looking at a rate constant for transfer between compartments. As I said, in an MR contrast agent, we're actually interested in going from vascular space to EES, going back and forth. And then we're actually measuring a rate constant, how go fast from A to B and B to A, okay? And a lot of things are somewhat unknown, so we're actually treating as like, this is a compartment, this is another compartment. We're just looking at how exchange rate it is, okay? So a lot of things are kind of considered to be a black boxes, okay? Again, drug administration, which is we are injecting a contrast agent. And in normal cases, in the clinical setup, it's automatic injection, so it is well controlled, and we pre-calculate the dose and the rate of the injection rate. So it is well controlled situation in terms of administration. And as I said, the clearance, mostly kidney, or depending on a different contrast agent, it can be the renal and liver clearance. But yeah, so this is more the liver-specific contrast agent cases. In general, most of other contrast agent is more the kidney clearance. Okay? All right, so back to here. As I said, there are 3 tissue compartments, right? There's a vascular space, extracellular, extravascular space, and intracellular space. And as I said, the contrast agent goes into the vessel and then going outside and going into the tissue, and then after that, for a certain time later, it gets back to the vein. Okay, and the MR contrast agent, as I said, it's basically between the vascular space and EES, and then we're measuring how fast it goes from plasma space to tissue space, and going back to the tissue to plasma space. So one is so-called K-trans. The rate constant from A to B is called K-trans, and a rate constant from B to A is called K. Okay? Any questions? Oh, yeah, sure. So you inject the contrast agent, it goes into the artery and then going outside the tissue, and then at a certain time later, it goes back to the vein and then cleared out. Okay? So the way that we measure is how fast it goes outside tissue and how fast it goes back to the vessel. Okay. All right. So we all start with the so-called fixed first law of diffusion. This is basically whenever you have two different concentrations, how it's going to change over time. So if you look at this, you have two different concentrations, and then it kind of diffuses together, and then becoming one concentration. This is governed by this fixed first law. The phi of D is actually diffusive flux, and C1 and C2 is a concentration in A and B, and PA is basically transfer constant. Okay, so the way that we measure is actually we try to measure this transfer constant by knowing what's going on in a diffusive flux and what's going on in this concentration difference. Okay, in the MR context, it's the same equation but different notations. The diffusive flux is basically CT changes over time, and then the concentration difference will be a contrast agent concentration in a plasma space and a contrast agent concentration in a tissue space. But there's a VE component because the concentration or contrast agent does not go into the intracellular space. So to compensate it, you need to know the fractional volume of EES. So this is 1 to 0, showing how much fraction in here in terms of the EES component. So if this is 1, that means everything is EES. If this is 0.5, means 50% is EES and 50% is intracellular space. Okay?
Sorry, for DC, we are measuring the perfusion. Here we do the diffusion model.
Okay, so let me cover that later. Yeah, what is the physiological meaning? Here, I didn't actually I didn't say anything about perfusion or permeability or anything. What I'm saying here is that you're measuring a transfer constant, which means how fast it goes from A to B, right? Okay, all right, so as I said, the contrast agent will go into the artery, and then it goes outside the tissue. But then again, in the tissue space, which is this, it will be consisting of two different compartments, which is EF, which is just interstitial space, versus intracellular space. But then the contrast agent does not go into the intracellular space, so it does not go into this gray area, it just stays in here, and then we're looking at the transfer constant between these two. Okay? So, back to this equation, right, from the fixed first law, you have this equation. I'm just rewriting it here, right? I'm just rewriting here. And then a few things you need to remember. One is, as I said, the tissue concentration is not the same as extracellular, extravascular, extracellular space. So you need to compensate it. To compensate it, there's a fractional volume, which is the fractional volume of EES. Okay? So CT will be equal to VE times VE times the CE. Okay? And another thing is actually we're looking into a plasma concentration, not the blood concentration. And blood consists of plasma and other components, and we need to compensate it. So blood concentration is CB, and plasma concentration is CP. And then hematocrit is the factor that we need to compensate it. And by doing that, we can actually go back and forth. The main purpose is actually sometimes people use different terminology and then ended up having a very different numbers. So to be clear, what number you're using or what notation you're using, this is very important. Okay, so once you have that, right, all you need to do is what? You need to solve this differential equation. Okay? So this is, again, very simple differential equation. And then when you solve it, then you have this. Okay? I know I cover a lot of different things, so on and so on, but this is the final outcome. If you remember this only, then everything is okay, right? But the whole idea here is this. you measure this, right? This is coming from SI of t. And then, for some reason, you need to know the CP of t. But assuming you know that, so here you know this and that, right? All you need to calculate is this K-trans and this KP. How do we do it? Just doing a curve fitting method, nonlinear curve fitting, because this is an exponential equation. So we apply the nonlinear curve fitting by assuming you know both arterial input function and tissue concentration. Okay? Then you're going to have K-trans and KP. And B is easy to calculate it because if you divide K-trans by KP, then you're going to have B. So this is somewhat interconnected. So when you have this equation, when you know this curve and do the curve fitting, finding the K-trans and KP, then you have some nice quantitative values. So as I said, K-trans is basically a transfer constant between the blood plasma and ES, kind of forward direction, and KP is a rate constant, and basically a backward direction. Okay, so I think you're asking about like how fast it goes in and how fast it goes out, right? This is basically kind of the quantitative value that shows how fast flux in and wash out. Okay, so typically if K-trans is high, that means the contrast agent goes into the tissue very fast, right? What do you expect in the signal intensity curve, right? It has to be really rapid, right? And if the KP is high, then what happens? Goes back to the vascular space really quickly, right? So what it does is actually this, right? So if you think about the signal intensity curve, so this is time, and signal intensity. High K-trans means you're going to have very rapid uptake, and high KP means very fast washout. And if you have very high, if you have high K-trans but low KP, that means you're going to stay like this. If you have low K-trans, then you're going to have very slow kind of uptake. Okay? So depending on the combination between the KP and K-trans and KP, you can actually kind of characterize different behavior very easily. Again, the KP is K-trans divided by VE. So it is interconnected. So in a feeding perspective, either you fit VE and K-trans, or the K-trans and KP. You can rewrite it KP as K-trans divided by VE.
How do you got this relationship between these two parameters?
This is basically how you assume it. Basically, from this equation. So KP is assumed to be this divided by VE. Alright? So you just kind of redefine KP value. Yeah. Any other questions so far? The natural question is actually, what about CP, right? I didn't mention anything about CP, and I said like, okay, you magically kind of assume something or you have something, but how do we know this CP? Because CP is important, right? This is input. How much contrast agent goes into the vessel, right? If you don't know that, whole equation will be kind of messy, right? Or the number will be very different. So how do we measure CP? Or how do we assume CP? What? Can you say one more time?
Something like pulse.
Like what pulse? Okay. So you're saying the injection in a vein will be the same as in some tissue?
Something like pulse on the with some response. I don't know.
Okay, just feel free to say anything.
Because you assume mass conservation, so maybe it's uniform distributed, so you can just calculate PT.
So
Y by 1.
so let me put it that way. So you can assume injection will be identical, right? Again, as I said, there is a like automatic injection. So the rate and dose will be almost identical for all the cases. But does it mean that you're injecting same kind of Gaussian shape means it's going to be the same as certain tissue location? Right. Right. Then how do we do it? Yeah, so the easiest way, or kind of the logical way to do it, is actually try to find a surrounding vessel and then try to measure that vessel kind of signal intensity and then try to convert it to a contrast agent concentration. But the tricky thing is actually normally the input function has much higher concentration, so it's hard to measure exactly. I mean, I'm going to actually talk about it a little bit later together, but okay, there are two different ways. Either you're assuming something, because as you guys said, we're injecting in the same rate, right? So the variation in different people will be maybe subtle. So that's how they do that. They're kind of assuming certain model. When you inject the Gaussian shape, and then it's going to circulate into the body, then either it goes to the single exponential or double exponential, which is bi-exponential model, or bi-exponential with the linear, or single Gaussian with the exponential. There's a reasoning behind, but they're kind of creating some sort of model, and then trying to fit that parameter by having a multiple input function measurements. So they measure maybe like 30 subjects, and then try to fit that parameter to certain model, and then try to use it for rest of the population. That's so-called population average AIF, or another method will be subject-based AIF. But then the tricky thing is actually, if you look at the vessel changes, it changes really fast, right? Because, this is not about the subtle changes. The input function should be earlier and much higher, something like this. So you have to kind of find a way that subtlety, that means you need to have a very high spatial resolution because normally the vessels are small, and high temporal resolution because it actually changes really fast. And I'm not sure Dan covered it, but there's a lot of flow-related issues. You need to compensate all this flow enhancement, so on and so on. If you don't compensate it, that means you can measure it, but the measurement won't be the same as true input function. So it is a kind of ongoing project, and people try to kind of find a way to measure a subject basis AIF, but again, it's very technical and challenging. The more practical solution in the clinics is to use population average AIF. So bi-exponential model is actually one of the most popular ones, or a single Gaussian with the exponential model is also another popular one. So they actually named it. This is Weimann model, and this is a Parker model. So those two are the most popular population average AIF. And I would actually say in the clinic, in a practical clinical setup, they're mostly using a population-based AIF rather than a subject-based AIF. Okay? So there's a way to do it, but the key thing is actually you need to be very careful because, as I said, assumption of CP and CT is critical to calculate K-trends, right? So in this situation, I'm actually showing a double exponential model. It's called Weimann model. And then if you use Weimann model and assuming that, so this is CT of T that was computed from the signal intensity, right? So you measure something at a certain location, and you're assuming this, right? Then you're feeding here, right? Then you can actually calculate the K-trends and KP. In this case, this is KP, right? Okay, by definition, again, KP is K-trends divided by B. Then you can find the curve. So this is, you assume CP, you measure CP, and then using this equation, you're trying to find the K-trends and B that fits the best, right? Then this is a value, okay? So K-trends is 1.3 and KP is 1.9, right?
Functions here, the CP is
certain location of the blood vessels or the lower blood vessels? Overall.
I mean, that's a great question. A lot of people kind of speculating the global AIF versus local AIF. But here we don't really care. We're just assuming everything to be the same. But sure, there are some papers talking about global versus local. They're actually behaving differently. So there's the differences. But here we're ignoring all the differences, just assuming CP is the same thing. Not only the location, but also different people. Okay? So very simplified model. Okay, so this is the K-trans value, right? So what if you assume different AIF? This is, again, Parker AIF using a Gaussian followed by the exponential decay. Then, again, you have a fitting, right? But the K-trans value is different. Okay, so CT is the same, right? I mean, we're not changing CT. We're just using a different AIF assumption. And then the K-trans is different. So the key component is actually, sometimes, many researchers, they kind of like treating the PK modeling as a black box, and then treating the K-trans as a final outcome. But if you don't know the assumption of the arterial input function, then all this calculation, because maybe institution A, they use Parker model, institution B may use Weimann model, right? Then even though there's no difference, there's a huge statistical difference between A institution and B institution, okay? So you have to be very careful because the way that you calculate the K-trans is heavily dependent on what AIF you're using, okay? Another case is actually you measure the arterial input function by putting the local vessel, and then you try to fit it, and then using it, again, the K-trans value is different, right? It's the same CT, but then one has 1.3, the other has 0.35. There's a huge difference between K-trans values depending on how you assume your arterial input function. So you have to be, again, very careful on that. Okay, another thing is actually somewhat related to local kind of issues, like arterial input function could be different in a local structure, particularly if you think about the tumor versus normal vascular structure. The tumor has very different structure. It's very unorganized, very random, whereas the normal has actually kind of organized fashion, right? What that means is actually, if you have a contrast agent here, if it's kind of like well organized and then long, then it may actually disperse at a certain point. Whereas the tumor, it's unstructured, everything is going fast, A to B, then your contrast agent may not be dispersed too much. So the idea behind is actually, if it's normal, then there will be more dispersion of the arterial input function. If it's a tumor, it may not have too much dispersion in an arterial input function. So even tumor versus normal, there could be a difference in a dispersion of that contrast agent or the input function side. Okay? So it's been kind of showing in different publications. Particularly, they're starting with the brain DSE and also the contrast ultrasound imaging, and also recently a DCE-MRI too. So again, the idea is actually we can include a dispersion factor in the arterial input function. So when you see this, it's going to be having the high beta, which is more dispersed compared to initial kind of arterial input function, and then you can include that factor into your DCE calculation so that you can differentiate better. Okay, so back to that, this is a standard method measuring a K-trans and KP by having a CT and CP. And this is so-called dispersion method. Again, you're assuming certain kind of parameters to be more flexible, including a dispersion factor into it, and then you're putting this back to the CT. The issue is actually there are so many parameters. So recently we actually developed a so-called modified dispersion model, which is kind of like simplified so that the feeding process could be much more robust. So the idea is actually similar, kind of considering a different dispersion factors, but then the 3 parameter is just only 1 compared to additional 2 in this case. So again, this is an example of the dispersion factor. So this is a conventional dispersion method looking at different kappa. So high kappa means, I think the low kappa means highly dispersed, like this. And high kappa means no dispersion, like very condensed. Same thing, we're actually using a beta function, which is representing the dispersion. So the beta 0 is actually no dispersion, and high beta is actually highly dispersed. So you can see for highly dispersed case, they're looking very similar. But then the way to achieve is actually, in our case, it's just simpler because it has a much smaller number of free parameters. Okay, so this is an example of the prostate cancer. We actually segmented as a transition zone and a precursor zone and a whole prostate and a lesion, which is the prostate cancer. This one has, I think, the 3+4, and this one has a 4+. No, this one has a 4+4, and this is 3+4. What that means is actually higher number in a Gleason score than is more aggressive. So this one is more aggressive than this. And if you look at the lesion side, I mean, this one is more kind of slowly enhancing, whereas this one is more rapidly enhancing. So if you look at the curve fitting by looking at different AIF, this one is kind of like having a very narrow assumption. This one has very wider kind of assumption. Depending on how you assume it, the fitting is not perfect. So meaning, in this case, this fits really well because it's well dispersed in the assumed AIF. This fits better than this because it has tighter AIF. So depending on when you try to assume, I know this is kind of too hard to understand it, but the main idea is actually the tumor types, depending on different tumor types, the behind dispersion effect will be different. And by assuming a single AIF may not be able to kind of represent all cases, by including a dispersion factor, it actually fits in both cases. In the same way, you can achieve using a modified dispersion, but having a lower number of free parameters. So the end goal is like this. So this is a standard Tofts model, and the histology kind of background, the ground truth. You can see there's a couple of areas that are kind of like false positive, but this one is much more cleaned up and showing much better contrast to show a tumor region by using a dispersion model. Okay, so it is ongoing. This is one of the projects that we're working on, trying to improve the pharmacokinetic modeling. And again, the end goal is actually try to find a better imaging biomarker to depict a good tumor delineation. Okay. Any questions so far? This is combination of the K-trans and dispersion factor together. And this is a K-trans map, right? So this is a K-trans map only, and this is a combination of the K-trans and dispersion factor.
So, if I understand correctly, you can use the K-trans factor to distinguish between how a tumor is aggressive, and so you will compare different patients. But is it possible that a different patient has a different function, arterial function, characterized better, just because our circulatory system is different? So then how can you, since depends on the arterial factor function, you change the K-trans, then how can we compare the two of us for aggressiveness of the tumor?
Yeah, so I think that's a great question. To answer that question, I think this is still ongoing. People are looking at it. Particularly the issue is actually, as you said, we're not sure how different it is across different patients, whether they have a different input functions or not. So that's one, right? Person A versus person B. And also within person A, there's a normal tissue and a tumor tissue, right? Tumorous tissue. And then also there's a difference between normal versus the tumor tissue in terms of arterial input function. So there's some complexity included, but I think the bottom line is people assume that differences will be lower than actual K-trans differences. So even though there are the subtle differences, you still can actually capture that huge differences between a fast uptake versus slow uptake. But I think if you really want to kind of looking at a longitudinal studies and drug responses those kind of very careful quantification numbers, I think including the considerations of that heterogeneous AIF across patients and across different tissue types, that's very, very important. Does it make sense?
Yeah.
Any questions so far? Okay, so I guess someone was asking about the physiological meaning, right? So the physiological meaning is very critical. So as I said, we didn't say anything about perfusion or something else, right? We're just saying we're measuring a transfer constant going A from B, right? And B to A. Again, the AIF is important. Try to understand the K-trend value. But another thing is actually, what is the physiological meaning, right? I mean, the fact that you're knowing that it goes fast from A to B, does it really mean it's perfusion? It depends, right? I mean, in a tumor, you can, because the permeability will be really, really, so let's put it that way. So in a different tissue status, the permeability and perfusion will be actually acting together, right? If it's like really high permeable situation, meaning everything is kind of going really fast, and then the transfer constant is only governed by flow or perfusion, right? Meaning in a tumor, it's very leaky, right? Everything is leaky. So in that case, when you measure a K-trans in the tumor, that's a perfusion. But in a normal situation, it's going to be a mix of permeability / perfusion. Because normal tissue, it's not going to be that leaky. It's going to have some permeability issues too. So in a normal situation, it's more mixed situation. In a tumor situation, it's going to be more high permeability. It's more kind of, the K-trans is showing more perfusion imaging. So that's why people kind of call it as a perfusion imaging as K-trans value. Because in a tumor, it has high permeability. So the K-trans is fully representing more tumor perfusion. Any questions? Again, so another thing is actually, in some situation, we're excluding this vascular space, and we're just kind of purely seeing this versus that. But actually, we have to also include the vascular space into the pharmacokinetic modeling. So that's the term that we added. And then basically, it's the same thing. You're assuming CP and CT, but then you're also measuring a VP component together. VP is also a fractional volume of the plasma space. So in this case, you have to measure a VP, VE, and K-trans. And VE plus VP plus intracellular space should be 1. Okay? So VE is a fractional volume of this gray, light gray, and a VP is the fractional volume of this area, and then this darker gray is intracellular space. And everything together, again, is a fractional volume, so it has to be 1. Any questions?
Volume of the vessels.
Yeah. So when you measure a CT of T, you may actually consider that is only including a EES and vascular space and intracellular space, or it only has EES and the intracellular space.
So in this case, we consider the CT as a signal we extract from both the plasma and the
Yeah, so it depends on the tissue. The prostate cases, typically the vessels are not that spread out too much, so it's okay to assume you don't see anything, because normally VP is really, really fractional, really small. But in some other tissues, you may actually have to consider this VP component. Oh, okay, yeah. So, that's a good question. So VP plus VE plus maybe intracellular space should be 1. This is a fractional volume. Of plasma. And then this is fractional volume of EF, and then this is a fractional volume of intracellular. Okay? And in general, depending on how you assume it, standard Tofts model, we're considering this to be very negligible, so to be 0. But in other situations, you can actually keep it as it is, and then you have to use extended Tofts model. Okay? So in other words, standard Tofts model assumes B plus BI is almost equal. Okay? And an extended Tofts model is basically BP plus BE plus BI. Okay, so this is pretty much kind of the summary of what we covered so far. So again, can you see here? Well, all right. So I covered about the quantitative DCE. Okay. So again, it all starts with what? SI of T, right? And then it goes to T1 of T. And then it goes to CT of T, right? And then it goes to K trans and KP. Okay? Okay? So from SI to TI, right? You need to know what? PR, slip angle, right? And then using that, you can calculate the relaxation changes. And from T1 of T to CT of T, you need to know what? T10, right? And CT of T to K trans, you need to know what? CP of T. Okay? And this is so-called MRI modeling. And this is called Pharmacokinetic Modeling. Okay? And normally, as I said, to go from SIT to T1 of T, what you assume is basically signal is proportional to what? There is a signal equation based on SPGR, which is 1 minus exponential TR over T1 sine theta, right? So using this signal equation, you know this, you know TR and theta, you calculate T1 changes, and then, oops, sorry. And then from T1 over T to CT of T, what you need to know is 1 over T1 over T is equal to 1 over T1 0 plus relaxivity times CT over T. Okay? And then the third one, the last one is what? CT of T going into K-trans and KP is basically CT of T is equal to K-trans 0 to T CP of T prime exponential KP T prime. So I know I actually kind of cover a lot of different stuff, and sometimes that's why when people talk about DCE-MRI, not many people actually understand what they're talking about. Because there are multiple steps, and this is definitely needs strong MR physics, right? This is definitely needs more kind of pharmacokinetic biology related understanding. And this again, this is what you know what sequence you're using. You have a control on TR. You have control on the like the side, and then based on that you can calculate it. This one you need to know the good T1 mapping method. So again, definitely the MRI modeling portion, the MR physics is really required. And then PK modeling again, so a lot of cases if you look at the DCE-MRI papers, some people are coming from the MR physics portion, tackling this or that. Some people are coming from more biology side. They're tackling here only, and then trying to say, instead of this, we are having a better kind of modeling. It fits better, and it gives better physiological understanding. So there are multiple components, but again, the bottom line is actually you need to understand each component very carefully. And again, each equation is basically representing the steps. Okay? Any questions?
I have a question.
Sure.
So what's the relationship between perfusion and flow? Similar questions.
No, I mean, I think that's a good question. I mean, in this context, I think you can actually say flow is same as perfusion. But again, it depends on how you define perfusion. I think things would be tricky. I mean, particularly in a DCE MRI, you have to be very careful. Again, as I said, depending on the tissue status, it doesn't really, the K-trans is not really fully representing the perfusion or the flow. So it only kind of like makes sense in a tumor. So sometimes you have to be very careful to try to understand what that means. So in many cases, my recommendation is actually don't try to kind of map one-to-one. Sure, there is a kind of representation, some sort of like the kind of showing of the flow information in the tumor, but in the meantime, the outside area is not purely showing a perfusion. It's actually mixed cases, right? Unless you can completely separate those out, K-trans is just K-trans, right? So to kind of answer your question, I think you have to be very careful to understand it, not try to kind of map it like a one-to-one. Rather, I would actually say you have to just use a K-trans by itself, and then try to kind of see that has an inherent meaning, particularly in the tumor area, that has some meaning of the perfusion.
You're more interested in the tumor, right? So for tumor, it's more like flow-like. So.
Yes. But we're not really differentiating tumor type based on the purely flow information. So it is, sure, it is representing or showing some information in a flow in the tumor, but not necessarily kind of showing flow only. The K-trans has actually more information and kind of different aspects of information.
Yeah. Well, in this case, you're not doing a flow MRI, this concept. You're not doing any.
Can you say one more time?
So what's the you actually like your flow, for example, this concept MRI. So I guess it's not the case. It's different.
Yeah, this is so kind of funny thing. Not the phase contrast, but the ASL. So ASL is also giving perfusion information. People try to kind of correlate the perfusion calculated from ASL versus perfusion calculated from DCE. There are some studies showing a good correlation. There are some studies showing not good correlation. So part of the reason is actually, again, it's not perfectly looking at the perfusion or the flow information only, because it actually include other information together. So sometimes, you know, in some situation it may not matching. It may not be matching really perfectly. Okay? All right, so that's kind of this section is basically kind of showing a summary of all the quantitative MRI procedure. As you can see, this is very complex, right? I mean, who can actually do it, right? I mean, you know, you need to know a good SI measurements, and then you need to put this. So, you know, historically, right? I mean, still people kind of wondering about what's the best software. And initially, I was also looking at software, and then it wasn't that clear, so I just rather decided to develop by myself. So we have some sort of software development too. And then again, as I said, it requires a lot of different things, because you need to consider a good T1 measurements, you need to know the conversion from the MR signal to concentration, and not only that, sometimes people want to actually analyze based on ROI, or pixel by pixel, or curve basis. You know, there are different needs, and also you need to handle a large data set. Typically, the DCE-MRI, as I said, it's a 3D with time, right? Number of images could be like, you know, thousands of images, and you need to handle that. And you know, a lot of cases they want to actually see the K trends or the final outcome, but in the meantime, you need to check each individual steps. So we actually use so-called Osiris platform. This is free for. It used to be free for Mac. Now it's actually not. There's a free version too, so don't worry about it. But it's actually open source medical imaging processing software. You know, surprisingly, it's actually coming from when Antonio Rosette was at UCLA. So he was a visiting scholar, I think from Sweden. Is that right? I'm not sure, but he's an MD. He's a radiologist, and he visited UCLA for a year. And then he was looking for a diachrome image viewer software, but then again, you know, turns out there's nothing, so he rather developed it, right? So that was around 2004, and then it came out really well. Now it's actually more commercialized. They got an FDA clearance, so they are selling so-called Osiris MD, and it's really popular. And if you have a Mac user, you know, it is really intuitive, very easy to use it. So anyway, the upside is actually they used to be open source, so we can actually develop multiple different plugins. Again, there's a different version, kind of forked out. It's called Chorus. Again, bad name, but again, there's a different free version available, so don't worry. But anyhow, we actually developed a software called DCE tool that actually has all the kind of capability. So I'm actually I have the screenshot of the videos to show the plugin. So in this case, this is the prostate, and then here's a vessel. So the closed vessel, and then this is the ROI, and then you can see this is the signal intensity over time. And then simple click, you can actually create a contrast agent concentration, and then you can define what's your baseline, and then looking at the feeding. And here you can choose different PK modeling, and here you can actually choose a different AIF function. And here, right after the choosing different AIF function, you can see the feeding. And here you can choose Parker instead, and then close it, and then you cancel it, and the feeding is updated. And also you can choose a subject-based AIF based on your ROI here, and then here is your subject-based AIF, and then you can choose some of the parameters, and then here you have the feeding. So again, it's very intuitive, kind of graphically try to accommodate all these possibilities, and then try to include all these steps carefully. So it is available. I mean, if you're interested, you can download it. Again, it's been used many different research sites too, because a lot of centers, they don't have a full capability on doing all the details. They want to actually use it by acquiring the, I mean, a lot of cases they have the data set, but they don't know how to analyze it. So they're using some of the tools like that. So again, this is an example using a prostate DCE. By having a signal intensity with the time, sometimes it's hard to kind of see what's going on. But having a quantitative value, it actually stands out really well. This is a K-trans map, by the way. Having a 4-second temporal resolution, you can actually have a very nice kind of showing a quantitative map of different tissue states. So, in summary, we are almost done. DCE-MRI has great potential. Particularly, it's actually well used in a prostate imaging and breast imaging. Those two are the main areas that people see the great value. In many cases, because it's a quantitative imaging, you can actually do a longitudinal studies and also looking at the recurrence or response to therapy. So a huge potential to be used in a response to therapy and drug development too. PK parameters can represent a different meaning depending on different assumptions. So again, that goes back to the question related to whether it's perfusion, purely perfusion or not. Again, my kind of take-home message to you guys is actually you have to be very careful. Try to kind of think of K-trans, try to map directly to perfusion because it may not be the case in some situations. Sure, it actually represents a lot in terms of perfusion kind of component, but also in the meantime, it has some other components included too. Understanding possible sources of error is very important. As I said, there is an issue related to B1 variation, and also the arterial input function has to be well carefully assumed. Without knowing those issues, just using K-trans value and then applying a statistical analysis with different groups or something may be risky because this is, as you can see, there are multiple steps and multiple requirements, multiple assumptions. If you don't carefully understand those assumptions and the steps, again, it has a lot of risky factor included. That's also one of the reasons that the DCE-MRI has been out there quite a while, but still people are working on it because, again, it has very complex process included. Okay, so standard imaging protocols and image analysis are important. Particularly, people are very interested in kind of using MRI for measurement device. So initially MRI was developed as an imaging device, right? Just showing an image quality, nice image quality is good enough. But now people are actually looking into more functional information, more kind of quantitative imaging, and a lot of faculty members in our department is also very interested in looking into a quantitative imaging biomarker. But then you also have to think about it, right? If you're going to actually develop a quantitative imaging biomarker, it has to be reproducible, repeatable, right? If you're thinking about you're measuring your weight, right? Depending on what scale you're using, if the number is different, how do you trust that, right? It's exactly the same way. I mean, if you're going to measure a perfusion or some diffusion information or some other functional information, if you go to scanner A versus scanner B, and then the numbers are not the same, or day 1 versus day 3, if the numbers are not consistent, then it's going to be a huge problem. So nowadays, people are more interested in looking at, okay, so we have developed a lot of quantitative biomarkers, but also, is it really reproducible, repeatable in multiple vendors with multiple scanners? So for example, even in a Siemens, right, UCLA, we are kind of big Siemens site. We have 18 different scanners, but then we're not having the same types of scanners. You know, some scanners have like 10 years old. Some scanners are 2017, right? MRI scanners are expensive, so the hospital cannot, buy the all new scanners at the same time. Some of the scanners are really old, some of the scanners are really new. Then there's a heterogeneity. One has better performance, the other doesn't have a good performance. Again, that's within the same vendor, right? The UCLA has, again, a lot of scanners are Siemens scanners. So within the same vendor, there's heterogeneity. But then if you include a multi-vendor situation, it's disaster, right? So people are working on it, and people understand the issues, and then they try to kind of change the things. But again, it's not going to take like within a year or something, because again, the machine by itself is very expensive, and it will take a lot of time to change, different machines, different techniques included. So it is ongoing, but what I want to say is actually reproducibility is important, and people are paying attention more and more. Okay, with that, thank you. Thank you for your attention.
That's great.